There's no harm in having a conversation with somebody who has experience, who's done it already. Because usually it's the unknown and the worry about that. It's better to know than not to know. And that's what saves lives, is early detection.
Welcome to HSE Talking Health and Wellbeing. Today we're going to talk about cervical cancer. Cervical cancer is a cancer that occurs mostly in young women and can be prevented if we take a few key actions early. Here to talk about this is our consultant, Dr Caroline Mason Mohan, who is Director of Public Health for the Screening Service. And also we have Catherine Heaney, Healthy Communities Project Coordinator for Dublin City Community Cooperative. You're very welcome today, ladies. Thank you very much for joining us to discuss this really important topic. Caroline, I think we'll start with you. Can you just explain to our listeners what cervical cancer is?
Yeah, it's cancer of the cervix, which for people who don't know what the cervix is, it's the neck of the womb. And it's caused by HPV virus in the vast majority of cases, well over 90%, probably well over 95%. The more we learn about it, the more we know it's the cause. And it's a very common virus. Most people will get it at some point in their life, but for most people, their immune system will get rid of it. It's the not clearing the virus that puts you at a higher risk of cervical cancer. You get it through sexual contact, but it doesn't need to be full sex. Your close encounters of a sexual kind will pass it on as well. But as I say, it's there. It's just a very common thing. And so just some people are unfortunate that their immune systems are not able to deal with it. But because we know it's caused by the virus, we can deal with it. We can prevent it with vaccination. There are lots of different types of HPV. There's probably hundreds of them. Some people would be aware of things like warts that can be caused by HPV, but most of those types are not going to cause cancer. But for a few, which we can vaccinate against most of them, they can lead to cervical cancer, but other cancers as well. We also vaccinate boys now as well as girls. And that's great because if the boys don't have HPV, then they can't give it to the girls and the girls are protected against cervical cancer. But I think it's important for boys and mums and dads of boys to remember there will be benefit to their boys as well, because it causes things like cancer of the penis and cancer of the anus, which is the back passage, and also cancers of what we call the oropharynx, which is the back of the throat. Getting the vaccination protects against those cancer-causing viruses. And wherever they go in the body, there's a risk that they can actually cause cancer.
Yeah, there's a lot of information in that. So if we break it down and we talk about maybe the HPV vaccination, because that's a relatively new vaccination.
Well, relatively new compared to the ones that we've had for 40 or 50 years.
Yeah,
it's a well-established, well-researched and investigated vaccination. But within Ireland, we've only had it since 2009, 2010 is when it was rolled out in the schools for the girls. But we've come quite a long way, even in those, 14, 15 years. We've expanded it to boys as well. We've included more of the HPV types. There are different types of the vaccine, and we've got now a vaccine that can have an effect against 9 of those. And those are the ones that are the most risky ones in terms of cervical cancer developing. If your immune system hasn't dealt with the virus, it can sort of lurk there, really. And while it lurks there, it gets into the cells and it starts to change the way the cells look. And that can then become cancer of that area. It's just we know a lot about the cervix. We know it's very connected to the cervix, and you very rarely get cervical cancer if you haven't got HPV there.
Catherine, you're really trying to help in the communities to promote cervical screening and the HPV vaccination throughout communities and the communities you work in. But first of all, maybe will you tell us a little bit about your role within the communities?
Yes, so we're a Cilantro Care Healthy Community site, and we were established, we were a pilot site, we started in 2021. So we deliver services such as the Healthy Food Made Easy, the We Can Quit Stop Smoking. We have a social prescribing programme. We do work around health literacy, which this ties into as well, and also work around mental health and wellbeing. But cancer prevention and promotion of any of the screening services link in with our work, especially around that kind of health literacy piece and promoting early detection. So I suppose it's really about being available on the ground in the community for information, I suppose an a point of contact for people who might be looking for some support around accessing services. as well as accessing the services that we deliver.
Yeah. How would they know to come to you for this service? Or is it just as part of maybe some of the more formal training or more formal programs that these type of things like cancer prevention will come up or cervical cancer will come up? Or how does it work?
Interestingly enough, all our work is very, very interconnected with each other. So obviously the healthy food and the week and quits are very prescribed. They're 6-week courses or 10-week. They're free. They deal with people in a structured way. So conversations happen in those as well. We also deliver our social prescribing where we work on a one-to-one with people. And it's very intense work. And it's work where you build a relationship with somebody and you build trust with somebody. And sometimes things like this can come out. People might want a little bit of support and might have a worry. And sometimes that conversation can happen. We also provide a coffee morning, which is open to anybody in the community. The idea about that was to actually have somewhere that people didn't have to commit to something for a certain amount of weeks. They could drop in or drop out as they see fit. And that's growing every week, actually. But it's a very informal environment that questions can be asked. If somebody, let's say, gets a letter or needs a form, help with a form, we do fun activities as well. We run things like our chair yoga on a Monday morning as well. But we would use that space, again, to promote different services. And if somebody wanted to help registering or knowing if they were even entitled to and what was it and all of that, the community health workers, because we have a health team, community health workers are available there. So we have myself, which coordinates the programme. We have a full-time social prescribing link worker. We have a full-time community health worker and 2 part-time community health workers. So they're very embedded in the community, 2 of which are born and reared in the northeast inner city and are known and are trusted. And trust is a big thing. So you build that trust up by linking with people every week. When they trust you, they ask questions like this. So we use that as an opportunity to promote screening service, to promote vaccinations, promote people going if they have an issue, making an appointment with their GP or help all of this. So, and it's really important environment to do that because it's a very relaxed, informal environment.
Okay, so somebody might pop into the coffee morning or something to say, look, I've got this letter, I'm really scared, I don't want to go. And people who work with you or yourself, you might say, explain to them what it is, what screening is about, why they should go for their cervical screening or why they should get their HPV vaccination and encourage them because they trust you.
That's it. Yeah. And I mean, that was one of the reasons why when we were approached and asked if we wanted to take part in the Screening Champions training, we jumped on it because the health team were completely situated in the right place for that. And we also, the refugee support worker in the COA, in their organisation, also trained as part of that because she would have a lot of contact with new communities as well, whom we thought would not know or know how to access those, but yet may be entitled to them. So we could work together as an in-house collaboration around promoting that.
That's really good. What do you think are the best ways to break down the barriers? Because they're difficult conversations, I'm sure, for some people that Catherine is having.
Yes, yeah. From the screening point of view, we work very closely with patients and advocates in developing our information materials. So we're hoping that we're answering the questions that people want to know.
You're working with your patients and patient representatives. You're developing the literature, the leaflets for people as they would want it.
Exactly. And then we share that widely as well. We share a lot of information on our website. And again, it's people's stories, people within the services stories. So it sort of humanises the service a bit for people. And we also do a lot of work with the people that do the screening for us, which are mostly practice nurses and GPs. And there are a few clinics that do it as well. We have them all registered as screeners with us. And we have a very varied programme of training across a lot of different subjects, communicating with people, as well as actually how to take the sample and so on. So that's a very good source of information for people within the context of actually taking the test, that you can get your questions answered there by people who are informed as well. But I think what we're concerned about, or what we would like to improve, particularly with the work we're doing around eliminating cervical cancer, is getting to people that wouldn't normally come. And so it is about understanding what is keeping them away. Sometimes it's just practical things like getting to the screening, getting a GP and all that sort of stuff. Yeah. That's why we're really pleased to be doing the community champions work and working with Catherine and her team around getting to people who we wouldn't get to in the HSC with our leaflets or whatever. There's plenty of reasons why that wouldn't work for people, even though we do our best in terms of developing those. But to actually get that personal touch, I think, and that trust that Catherine's talked about is really important to get the people that don't come. And we know that for people who are in lots of ways more prone to chronic diseases and various things, and including cancers and cervical cancer, that they're less likely to attend the preventative things that we've got because of things we potentially put in the way of them. And if we can get those people to see that as a choice for them, it will improve the health of the population. It'll move us that bit further to eliminating cervical cancers. And also, we don't want to leave people behind. This is there for them as a service. They're entitled to it. But there's a bit of a gap between them having an entitlement and them being able to carry out that entitlement. And that's what we're trying to do, working more closely with communities, because we know that, and Catherine can talk better than me about it, but that personal touch and that understanding of somebody that knows you in terms of knows what your life is like and what the things that get in the way are, then it's much more effective in getting people to take up the opportunity.
So, Caroline, you're talking about eliminating cervical cancer, and how are we going to do that?
Okay, well, we are well on the way to it already, actually, but we know we can do it because we know what causes cervical cancer, and that's the HPV virus. And we know the vaccination can prevent it, and we know that screening can pick up changes in the cells early that we can treat fairly simply. And we know it also picks up, for some people, it will have gone as far as cancer by the time we get there, but it's much earlier and again, easily treated. And for some people, that treatment is not much more than if they just had the non-cancerous changes.
Yeah.
So there is a lot of opportunity there for people. And we have good treatment services here then for people who do develop cancer to treat it. So we know that if we can maximise people attending for screening and vaccination and then following through and getting the treatment, we can really bring down the amount of cervical cancer that we have in our population. And so what we're aiming to do is make it rare. And we're joining in a sort of global initiative around eliminating cervical cancer. And the WHO have set parameters for that. They've set some targets for us to meet. So we're doing pretty well on them. 90% of girls vaccinated by the age of 15. And we're up above 80%. We're heading towards 90. But, it's the sort of work we're talking about is every girl that we get vaccinated is somebody that's so much less likely to get cervical cancer and contributing to that. And 70% of people screened is the target. We're already over 70%. But the more we can get in, the quicker we'll get to elimination. And then 90% of people treated, and we're pretty much at 100% on that. We have worked out from where we are in Ireland when we might achieve that. And if we can achieve those targets by 2030, then we should achieve elimination by 2040. But we could get there quicker if more people come, but we at least need people to come that are already coming. There's a really big opportunity. And beyond 2040, we will get to 4 cases per 100,000. But beyond 2040, if we continue, it's every likelihood that we will get lower than that and it'll become rarer.
Yeah. I mean, it's just mind-blowing that we've got to this stage. It's just incredible. So the message is just for everybody is to get your HPV vaccination, go for your cervical check, and please follow up with your treatment. But what do you say to the people who are talking about vaccinations? And you mentioned earlier on, we've had vaccinations for the last 40 years. And of course, then we've had the pandemic in and out between, and there was vaccinations for that. What do you say to people who are just saying, that's it, I'm done with vaccinations? They're difficult to get to convince that this is proven, it's evidence-based. So what would you say to people like that?
Yeah, and it is very difficult. I think, though, we forget that the reasons some people don't go for their vaccination just because they don't have the opportunity to get them. For some people, it's difficult. Girls are not always in school on the day that the vaccine comes, and then it's quite a journey to get to a clinic to get it afterwards. And it's sort of the practical things often that stop people getting vaccinations, or they don't know enough information about if a child has had sort of illnesses through their life, that the parents are a bit concerned that if they take a vaccination, it might not be good. Whereas if they had that conversation with somebody, which they can do through their GPs and practice nurses and so on, then they can get advice about whether this is appropriate for their daughter. And there's very few reasons why you can't get the vaccine. In terms of the other pieces, we do share a lot of vaccination information and the evidence behind it. But for some people, it's not the evidence, it's more how they feel about things.
They're the people I'm talking about, really.
Yeah, exactly. And I think the sort of thing that Catherine does, and that sort of sharing stories and experiences and that sort of personal touch, is really the way to support people who have genuine reasons why they think this is not for them or for their daughter or son. And I think having that opportunity to have those conversations, I don't know if you agree, Catherine, is probably the best way to support people like that in making the right choice for themselves and for their children.
Absolutely. You can't force anybody to take up a vaccine. But what I would say is smallpox has been eradicated because of vaccinations.
Yeah.
So if you think vaccines don't work, that's a classic example of actually, well, they do. I think it's more people are hesitant rather than they're not anti-vaccine. Yeah. They're just a little bit, they want more information. But I mean, let's be honest, you have the internet. It's about saying to people, the evidence is there, but you need to look at the right places. And making sure that people are actually reading peer-reviewed websites with .edu, websites with .gov. Good peer-reviewed research is there to support this and encouraging that. And also talking to other parents who have had the girls vaccinated and everyone is fine.
Yeah.
So it is word of mouth is so important in communities. And I think you said it earlier about leaflets and posters. They're great and all. And I mean, they do work, they rate, but they can be conversation starters. Especially if somebody's like, oh, I don't know about that. And someone says, well, my 2 girls are vaccinated now and it was nothing and everyone is fine. And, kind of like you're always going to hear scare stories, which you do. You have to respect those stories. They're people's experiences. But again, I would say, look, we've had a drop in some vaccination uptakes and now we're starting to see things like measles. So, can see the relationship between the two of them.
And Catherine, is there particular challenges with any certain groups or different people within your communities that are really difficult to reach or you find it difficult to communicate with?
Well, yeah, because there is always going to be certain cohorts of people that are a little bit more difficult to reach and to have conversations with. We've done this piece of training. Our refugee support worker, Megan, also done it. And I suppose we've seen a very nice collaboration as we would promote this anyway, because we ran an information session on one of our coffee mornings, which was really well attended and people really responded very well to that. But what we did do was, I know Megan had said there's an awful lot of women living in direct provision. So we partnered and BIM, one of our community health workers, and Megan, the refugee support worker, went into direct provision sites. Initially, we thought we were going to have these workshop type things and we realised real quick that wasn't going to work.
Okay.
Because they weren't good and people had bigger fish to fry, in situations like that. So what we done was we kind of used it as a drop in and people came in for information and they got information. And strangely enough, we were having the conversation yesterday in the office and Bim was saying she was quite surprised at how many women living on the sites knew about the screening service, but had no idea how to get to it. Didn't know how to register it. He didn't know, how they got their screening done. When the team went in, they were able to provide that information. There was already a relationship of trust built up on these sites with the co-op staff and certainly with the work that the refugee programme is doing. And we were able to share that information with people, help people register. And people went for their tests. And actually, we had one person come back and they said that they very quickly registered, were entitled to it, went and had their test. And it turns out it was caught. And they had a tumour that they had no idea that they had. And it was caught and they were in treatment. I actually came in to say thanks because I would never have known because I didn't even know how to register. So there was certainly a piece of work there. When it comes to, I suppose, the broader sense, there's a lot of barriers, not necessarily with screening in particular, but even there's the digital divide. So not everybody has a smartphone or can afford data or has digital literacy or knows how to go on to a website and register or can do it correctly or know they've done it correctly. So there's a piece of support work to be done around that if they wanted to check to see if they were actually registered. There's also the time immemorial issue of waiting times and not being able to get in to see the GP. So actually letting people know that they don't actually have to have their procedure done in their GPs. They can go to a family planning, they can go anywhere. That was another thing that people didn't realise, that they didn't have to just go to a GP, so they can bypass that. And again, there is the certain cohort of people out there who maybe don't leave their house or can't leave their house or find it difficult to access health services because of different things and time. I mean, people with kids they put it off. Oh, I'll go or I'll organise it or I'll do it now next week or I'll forget and everything gets put on the long finger. And I mean, I think we've all been guilty of that in some way, shape or form with other stuff. So I think that can be another barrier to people actually getting their smear, getting their check done. There's many things, there's many barriers, but there's also a lot of enablers.
Yeah. No, that's really good. Did you want to add in something there, Caroline?
I just wanted to say it's this sort of conversation that is what we value about working with people like Catherine and her community. We do it elsewhere as well, but it's understanding what are the barriers to people and what would work for them. Because if we don't know what the problem is, we can't solve it. We've been guilty across the health services generally of solving the wrong problem. And we think if we put everything digital, it'll work for everybody. If we do this, it'll work for everybody. So we do in the screening service work through what we know to be the barriers for people. We have got easy read leaflets. We've got access to videos in different translations. We do our best to sort of understand what the problem is and then try and find a solution to it.
Yeah.
If you don't know what it is, you can't deal with it. And I just wanted to say as well that people can actually go to any GP surgery. It doesn't have to be your own one, as well as things like family planning clinics. So, we try and make it the front door to get the screening is as open as possible. And I suppose just to throw in your point about people that can't get out of the house, we are looking at the moment in cervical check at an interesting development that's happening around self-sampling. Still in early stages. Some countries have got it in limited rollout to population. We're interested in their experience of really getting to people who would have barriers to getting to services, and also maybe some stigma about that. That might be a solution in the future. So it's early stages, but we're looking at it again to try and just meet some of these gaps that we have for people getting their service.
And just the practical examples, the real life day-to-day examples of how you're getting to people and how you're accessing people and how you're educating people and giving them the information, Catherine. And like you said, that person who did have a tumour, that's what makes the work all worthwhile. And you're obviously learning. Caroline, you're then learning from what's happening in the community to try and constantly review, evaluate and improve the services based on the needs that Catherine is telling you about. And Catherine, did you want to say something there?
Yeah. So just about the self-sampling, I think you could reach so many more people. Not only people that have difficulty leaving the house, but also people that will put it on the long finger. Do you know, that kind of like, put it off. But you can't really put it off. The kit comes to your house. Do you know, there's also a lot of people out there who have trauma because of assault trauma or childhood trauma. And there's communities of women who have been victims of FGM who wouldn't be comfortable.
Just explain.
Female genital mutilation from certain cultures and would not go to, under any circumstances, go to have anything like this done. So a self-sampling kit could be a lifeline to those women.
Yeah.
Really a lifeline.
Caroline, do you want to go through the process of cervical screening and what happens when somebody goes in to demystify the procedure?
Yeah. A lot of women listening would have had a cervical screen. And I think, let's be straightforward, nobody really looks forward to doing it. It's not top of our list, oh goody, that's coming up. But like any sort of examination that the doctor might do, if you had any problems with your periods or anything, you'd lie in the bed, you'd speak to the doctor or the nurse first, obviously. They can answer questions that you might have and they'll explain what they're going to do and what test results might come out and so that you know what the next steps are. And then you sign your consent, pop up on the bed. As with any examination, you sit with your knees up, which is the bit most people don't like, really, I suppose. The nurse will have an instrument called a speculum that's just put into the vagina and just opens slightly so that then the swab can go in. And it's a bit like a long cotton bud, really, is what it is generally. It's got a little bit of a brush element on the end of it. And then it just quite quick goes in and out. And the doctor then puts that in a little bottle and sends it off. And then we have a standard of around 4 weeks. You'll get your result back. We're running pretty good to time at the moment. So you'll know fairly quickly. What your main result is that you will know whether or not the test picked up HPV, the virus. If it didn't, happy days, fine. You're off then for, if you're under 30, 3 years till you get your next test. If you're over 30, 5 years. And we know that a negative test is a very good predictor of your risk of cervical cancer. So you can have good confidence in that. Occasionally, it's a false negative, but it's a very small amount in that. And there's lots of evidence around why we can do 3 years and 5 years and so on. If it's positive, then we will have looked at your cells as well. There's a couple of results there. One is you're positive for HPV, but your cells are normal, in which case you'll just be asked to come back in a year. Because a lot of people get rid of the virus within 18 months to 2 years. What we want to do is for them to have a chance to get rid of the virus. One thing just to say while we're on, to support some of the stuff Catherine said about the QUIT program and everything, we know smoking is one of those things that might mean you keep the virus for longer. So one thing you can do for yourself is to actually stop smoking if you get a positive result. I mean, stop anyway if you can. But if you get a positive result, just bear in mind it might help you to clear the virus. But if your cells have got something on them, and that is generally just some changes in the cells, and we know these cells go back to normal, particularly if you get rid of the virus, then you'll be asked to go to one of our clinics. They're called colposcopy clinics. And then you have a sort of more elaborate version of the smear, really. There's a camera that looks at the cervix, and the doctors there are highly trained and very skilled at this work. And they will look at the cervix, they dab bits on it and things. They may take a little biopsy. They'll then talk you through the results that could come out of that. For most people, that's it. It's clear, it's fine. And the clinic then will tell you when to come back and what the review will be. If it's a bit more, if one of the results come back, then again, as I said, a lot of those things can just be treated quite simply within the clinic. For a few people, a very small amount of people, there may actually be a cancer there. But for the vast majority of people in colposcopy, if you get a positive colposcopy result, it's cell changes that are not cancer and can be treated and prevent it ever becoming cancer. And that's the main thing we're trying to do with screenings.
So it's early detection.
It's more than that. It's not the detection of a cancer. It's a detection of something that isn't cancer at the moment, but we know under certain circumstances, over a period of time, could be 10, 15 years, might become a cancer. So we get rid of it now. Those changes won't go. And if you clear the HPV, your risk is gone.
Okay, that's fantastic. So if you've had the HPV vaccination, do you still have cervical screening?
You do, yes.
Okay.
So the vaccination is against most of the cancer-causing HPV types, but there are some that have a very small risk of it. And you might be unlucky that you get an HPV that isn't in the vaccine, but still has a small amount of chance of causing a cancer. And you just happen to be unlucky that your cells, your cervix, whatever it is, that the reaction happens. But we do think that in the future we'll be, and this is the exciting thing, I think, that as more and more people are vaccinated, we'll have more and more evidence that we can actually, first of all, lengthen the period between your screens. And maybe get down to only a couple of screens in a lifetime, possibly no screening at all at some point in the future. So our journey to elimination will also probably mean changes in the process for screening. Yeah. And I'd like to sort of reassure people, that women that are listening, that isn't about trying to cut down the screening or cut down the service we give you. We spend a lot of our time looking, as Catherine was saying, at the literature and the research, and talking to international colleagues, and we contribute some of that research ourselves, and that we will be looking at our program to make sure that we're giving the best program we can according to the literature. And we've got, in Ireland, we had a paper last year that we worked on that showed that the group of girls that were vaccinated from 2009, the ones that are now over 25 and into the program, the first 5 years of those, not on an individual basis, on a sort of population basis, but the amount of the changes that they've got on the cervix, so they're called sort of CIN 2 and 3, are the ones that we treat. It's just plummeted down. They just don't have
So
them.
the evidence is there.
The evidence is there. And same in Scotland. Scotland, very good results, but we've also got it in Ireland. It's not just, it belongs to us as well.
We always look to other countries and stuff, and we have the evidence. I know some of this HPV vaccination was implemented in different countries a lot earlier than we have.
Yes.
And you've evidence there. And you
Australia,
mentioned, you've mentioned the WHO, which is the World Health Organization. So we're not insular. We're looking everywhere all over the world to make sure we deliver the best program possible.
Yes, absolutely. And in terms of the work that we did to try and work out when we could eliminate cervical cancer, we work with Australia, who are ahead of us, and they're going to eliminate by 2035 because they started vaccinating earlier and they introduced HPV-based screening earlier. And so they've got 5 years on us, but we're running to catch up on them. We were interacting with what are the experts around this in,
of course,
in
and you're learning all
the world.
All the ways of getting in touch with the communities and the difficult people to get, and how to communicate with people, and all of that, which is fantastic between colleagues in different countries.
Yeah, but there's that big sort of international piece. But actually, when it comes down to it, it's putting one foot in front of the other, taking a step at a time, with communities, working in partnership with people. That's what's going to get us to elimination. Everybody that takes a vaccine is another person that's very unlikely to get cervical cancer. And that's a big win. But I know from talking to Catherine and aware of her work, that every person that you get to take a vaccine or a screen, that's a lot of building of a relationship and trust and time into that. And I don't think that's always appreciated or necessarily valued by people like us in the health services, just exactly how much work it takes to do what is a very important preventative program to keep populations safe and healthy. And that's what Sláintecare is about, which is, where you're doing a lot of the work under the Sláintecare Healthy Communities. So just want to say thank you to Catherine, actually. And people like her for the work they do.
No, that's really good. And it's just fantastic to know that it is a realistic expectation that we could eradicate cervical cancer and get it to a minimum at the very least.
Yeah. Well, we call it elimination. Down to 4 out of 100,000, which is rare. But I would like to think that we will be able to do better than that.
Yeah. So we're coming to the end of the podcast now. And Caroline, what would be the main messages that you want to give to our listeners?
Well, I suppose the messages I've been giving through this podcast are that we can make cervical cancer very rare if we all take a bit of time to consider what we can do for ourselves. And so I would recommend that when that letter comes back from school about the vaccination, then read the leaflet, read the information. If you want more information on it before you make a decision for your child, then go online. We've got information on www.hpv.ie and make the right choice for you and your family. When the screening letter comes through, make the appointment, get the screening. Again, read the information, talk to your GP or nurse, go online. We've got a lot of information on www.screeningservice.ie. And then if after that, when you get your results back, that you need to go to a clinic, then again, talk to people, read the information, but go for the clinic appointment. The doctors and the nurses that do the colposcopy are very used to answering questions and explaining everything to you, and it could stop you getting cancer. So those would be my main messages. But I think also for people that are listening that are perhaps members of Catherine's community or other people that have got the support of community health workers, they're also a really good resource. And so get your information from people you trust. And as Catherine said, other trusty information sources.
Yeah. And Catherine, do you have a final word to say to our listeners or people like you who work in communities like you do?
I always have lots of final words. First thing is there's not a whole lot of free things in this world, and screening services are free. So I would say if you're getting something for free, take it.
Well done.
Because if you had to pay for it, by God, would you follow it up if you had the money? If it's free, have it. Have at it. It's being handed to you. Burying your head in the sand is not a treatment. The best treatment is to find out if you need treatment. Avoiding it is not actually a cure. So if you do get a call back, don't think for 1 minute that this is like the death knell. It's not. It just means something's a bit unusual and you want to have another little look. And that's okay. And that's free as well. If you have any questions, your GP and your nurse, very important, but other women love to talk to each other. Your neighbours, your sister, your friends. These conversations are had in Ireland, since time immemorial at the kitchen table. If someone else has gone for their screening, have the conversation. Talk to them at the kitchen table. There's no harm in having a conversation with somebody who has experience, who's done it already. Because usually it's the unknown and the worry about that. It's better to know if you have a next step than not to know. And that's what saves lives, is early detection. If you catch something early, firstly, it's much easier to treat, which means your treatment is quicker. And actually, you're going to be off work. The shorter period is going to save you money, or there's a whole load of positive reasons why if you catch something early, it's way better. There's far better outcomes. So don't leave it, especially when something's being handed to you for nothing. Like, why would you say no to that?
That's brilliant. They're very wise words, for sure, for finishing up on our podcast today in relation to cervical screening and cervical cancer. So thank you for joining us on today's episode of HSE Talking Health and Wellbeing. I hope our discussion with our very wise Catherine and Caroline has given you some good insights into cervical cancer prevention and how to protect yourself and your loved ones from cervical cancer. The screening service are working tirelessly in partnership and connecting with communities to make sure that cervical cancer is rare or eradicated by 2040. Remember to choose the HPV vaccination for our young people. Go for your cervical screening. Come in for treatment when advised. And for any information for a trusted source of information, go to the screeningservice.ie and hpv.ie. Just to let you know, November 17th is Cervical Cancer Elimination Day. And on this day, Ireland joins hundreds of countries around the world to show its support for the global movement to eliminate cervical cancer. If you want to find out more about this, you can follow the hashtag Together Towards Elimination. Thank you very much for listening.